And as Sarah said, it's very difficult to meet the people face to face. But I remember also, يعني, in a previous awareness, we always also hint that this breast cancer's awareness is not only for a woman, it's for a man also. And I remember one of my sessions, I think last year or the before last year before that, in 2018 or 2019, I don't remember. But also I mentioned that the men also, there is a chance for them to get a breast cancers. The chance is low because in the United States in 2019, they did a statistics, and they noticed that part of the breast cancer cases, 1% of the cases belong to or related to men. I remember also in the past, if someone had this disease or breast cancer, it means the probability of dying is a high, and they consider like a threat. But with such awareness for so many years in Bahrain, under the leadership of our leaders, I think they pushed the Ministry of Health and the whole organization to give more awareness on this disease. So, to me, now the breast cancer is no more a threat for anybody. Because if you detect it in early stage, this will prevent you from having it at the later stage. I will not take too much time because I know the people interested to listen to Dr. Suhair. And Dr. Suhair, to me, I did a Google also, some Googling, and I see her, she's specialized on general breast and cancers and a lot of medical related disease. However, I will leave the chance for the woman to impress their questions, because I remember after the sessions, a lot of the questions will be raised, and definitely I am sure Dr. Sohair, she will be welcome to answer them in a very professional way. By the end, I would like to thank also Sister Zainab for arranging this session with Dr. Sohair. And this is part of our medical responsibility, is to give awareness over all the time. And I think having such awareness campaigns at Alba, since we have a good numbers of women in Alba, maybe around 150 to 140 women, I think it is a big number today to listen and to give some awareness or refreshment. I will not consider this awareness as a new for them. It is sort of refreshment for their memories and their understanding about the breast cancer. By ending, I would like to everybody participating today to have a good presentation and to participate as much as they can, because this is the best opportunity for everybody to ask a question if they have a doubt. This is a free consultation, by the way. It will not cost them any money or cost the company any money. Once again, thank you, Doctora, for accepting our invitation to conduct such awareness sessions, and I wish you all the best. Thank you very much.
Thank you indeed, Mr. Ali, for your valuable words. Just like our CEO stated earlier, of course, Dr. Suhair غنية عن التعريف. She is general consultant. She's a breast oncoplastic, and also she is assistant professor in the medical college. Dr. Suhair, she has more than 30 publications in local and international journals. I'm sure that all of you will benefit from this session today. I'm looking forward, and I'm very excited about today's session. So let's learn about it and let's enjoy the session. Gentlemen, thank you for joining. And now we will start with the actual session with Dr. Suhair. Let's all welcome her.
Thank you, and wish you all the best. Thank you.
Thank you. Thank you, Mr. Ali.
عليكم ورحمة الله وبركاته. ما أدري صوتي واضح عندكم؟ الصوت واضح؟
إيه صوت واضح.
أوكي. هو ترى I would like to thank Mr. Ali Bakali and thank you Sarah and Zainab for giving me the chance to share with you today your activities of awareness on breast cancer. Breast cancer is a disease not only affecting women, just to insist on what Mr. Ali Bakali has said. It affects men in 1%. If you compare it to women, it's about 1% of breast cancer cases happens in men. So let us start by this. I choose this, heading that breast cancer is not the killer cancer anymore. Just to start with a positive statement early morning about breast cancer. We don't want ourselves to be thinking that it's a disaster. There is a lot of things now has changed in the management and the thoughts about breast cancer. So let us defeat breast cancer together. I don't know, it's not, the slides are not going up.
Okay. Is everything okay?
Yeah. I'm going to speak today briefly on, first, the mortality rate of breast cancer, which means the death rate. How many people are dying from breast cancer before and now? And I will speak to you about our protocol of early detection, diagnosis of breast cancer, and I will concentrate on triple assessment. I've chosen these headings just because I'm, with my experience with my patients, I think I need to educate them in these things because it will help them later to decide what to do whenever they have a problem. So the third thing is diagnosis, incidence of breast cancer worldwide and in Bahrain, age at presentation in Bahrain, risk factors of breast cancer, because we don't have clear causes of breast cancer. So we'll speak about the risk factors, how to prevent ourselves from developing breast cancer, breast self-examination, staging and treatment if it is of concern. Maybe it's not important in our presentation. And the last is conclusion. So to start with, I want to show you this positive graph. It's a graph which shows you the breast cancer mortality rate decline globally. As you have seen here, that breast cancer, as I told you before, mortality means the death rate. So the death rate is coming down. It's not high like before. Over the last decades, it has gone down to very low percentage. So this is a good thing. It doesn't mean that when we have breast cancer, this means death. Because why we had all this improvement in breast cancer mortality or this decline in breast cancer mortality? Because of 2 points. Early detection of patients, this is the first thing. Second thing, improved treatment options. We have now, I will speak to you about the early detection and what's the protocol of early detection of these patients. So how do we do early detection? Before we go there, I want to discuss with you the 5-year survival rate. What does it mean, the 5-year survival rate? It means the percentage of people in the study who received the treatment and after 5 years, they were still alive. So if you go with me, this is the international figures. Stage 0, which is very, very small tumor detected only by screening mammogram. Stage 1 and 2 is still in the breast, but small and have reached the lymph nodes. Stage 3, it's becoming big, but within the breast and in the lymph nodes. Stage 4, it has gone beyond the breast. So if you just see that in stage 0, the 5-year survival rate is 100%. And this is what we are aiming for. In stage 1, it's 98%. And in stage 3, it's 93%, which means that the 5-year survival of early breast cancer is above 90%. So this is what we are aiming for, early detection of breast cancer. So how can we reach that level? We are still lagging behind in the Arab world and in Bahrain and the Gulf to reach that level of detecting early breast cancer. But our results in early breast cancer is matching the international. And I will show you because I've done a study on my patients who had breast cancer and we measured the 5-year survival and the 10-year survival. It is like the international figures. It is above 90. But we don't have the percentage of early stages is not high like the international. The international, they have better now. They are better than us because they are detecting the breast very early. And I will tell you how we are going to improve our early detection of breast cancer. This is the study I told you about. I did it on 218 patients with breast cancer. This study, we found out that the early breast cancer, if you can see the first, which is written here, the first column, early breast cancer, the blue line shows the alive patients, and the orange line, orange color, shows the dead people. So in early breast cancer, we are 90.9% having 5-year survival. So it's almost close to the international. As you go down, it becomes down, and it's normal also in the locally advanced, which we have said there, stage 3, we are 73%, which is almost equal to the international. And so this means that we can get better if we detect the breast cancer early. We will make it a disease that it is not killer anymore by detecting it early. This is also a study I've done on we measured here the 10-year survival. We were still high in the early breast cancer. This means that our aim, which we want to reach by the end of this lecture, to work on getting patients in the early stages. So, if you see the first column on the graph, 75% of patients survive after 10 years, which is a good number. So how we do early detection? Early detection, I will explain it to you in details if you give me the chance. We will divide the people into people who presented without any symptoms. They are just coming for screening, and they are normal population without any symptoms. We will divide them into high-risk group, which we start their assessment, clinical assessment and radiological and all other investigation. We started at 35 years old or maybe less also. And the second group is the normal population. The second group is the normal population, which we usually start screening them at the age of 40 years and above. Who are the group also which we would like them to have early detection are the ladies who already started having symptoms and signs of breast cancer. We want them, all of us, to start presenting to a doctor at the beginning of their symptoms, not to wait until the lump becomes big or starts to ulcerate to the skin, or they start having lymph nodes in their axilla and then to present. So all these patients who had screening, either the high risk, the normal, or the patient who had symptoms, and they had to present early to undergo triple assessment. So if we just speak now, who are the high risk group? Because we said there, the high risk group, we should start screening them at the age of 35 or less. These are the women who had strong family history of breast cancer or ovarian cancer or any other cancer like breast, ovarian, colon, who had it in their first degree relatives. We mean first degree relatives, we mean mother, sister, or daughter. Or they have done a genetic testing, and they found that they have genes which are positive for breast cancer. The second risk group is the woman who had a previous biopsy or previous surgery in her breast, and the result came with abnormal precancerous cells. This will be written in the histopathology report, and these patients will be told by the doctor that they are high-risk group and they should be followed closely. The third people are the patients are the women who had mammogram, and her mammogram showed very dense breast. These are doesn't mean that they are going to develop breast cancer, but these patients are high risk because very dense breast, the mammogram doesn't show anything on it. So this means that they have to have close follow-up. Maybe something is hidden behind this mammogram, needs to be evaluated properly. So let us go back now. As we said, all these people will go for triple assessment. And this is very important because I have patients who's doing mammogram and ultrasound without any clinical examination by a surgeon. And then the mammogram and ultrasound shows normal findings, and then they stop going for a doctor. Usually we have to do triple assessment. Each one of them is an important pillar of diagnosing breast cancer. We cannot diagnose breast cancer with only radiological investigation. We have to have a clinical examination by a surgeon, a breast surgeon who's experienced. And if there's any lump, to go for the fine needle or the biopsy, fine needle aspiration cytology or biopsy. So I mean, triple assessment means 3: clinical examination, radiological investigation or imaging by any means, 3rd, fine needle aspiration cytology or biopsy. So I just want to show you here this video. It's supposed to work. It's not working. Oh, it's supposed to work, this video. Right click, no? Okay, it doesn't work, no problem. Oh, okay. I just want to show you this video because it will show you clearly how a lump will look like, and how you have to examine yourself and discover these symptoms early. If we don't have time, I will tell it in the questions. It seems like this will not work here. So. The second thing, as we said, about clinical examination, the second thing is radiological or imaging evaluation. There are many tools to examine the breast by imaging, but the most common ones are the mammogram, the ultrasound, and the MRI breast. If we start speaking about the mammogram, I think the mammogram has been given very bad rumors in the society, that it's not, it can spread cancer, it's not a good tool. Ladies have called bad words about it, but it's a very, very good tool, and there is no tool reaching the ability of mammogram to detect breast cancer. So it's still the best way to detect breast cancer. There is a lot of improvement in the mammogram. Now we have digital mammogram, tomosynthesis, which are all allowing us to take better pictures. So, and will allow us to see the breast from different views and different angles. So it will show us the breast cancer as early as possible. So if you have a look on this one, this lady has this whitish thing in her breast. You can see it on both pictures here. That turned out as cancer. Another patient here on the right top, on the left top, she had also an irregular lesion in her breast, which is the whitish thing. It looks like a star or like a sun with irregular borders. This is typical of malignant. So mammogram or mammography defines 84% of women who have breast cancer. I'm not saying 100%, but it is 84%. So we should not say that we don't want to do mammogram, especially for ladies above 40 or patients who are diagnosed to have breast cancer. Why we are saying only 84%? Because 16% will not be detected by mammogram. We will detect them by other means. That's why nowadays we combine mammogram and ultrasound together. So if we miss something on the mammogram, we will see it on the ultrasound. So I just want to remind you that above the age of 40, we have to have screening mammography, either yearly if we are high risk, or every 2 years if we are not high risk. So I just want to clear some of the facts about mammogram before we go, because it's a very, very good tool. And I have sometimes a lot of discussion with my patient to convince them to do mammogram. Today, modern mammography equipment produces high quality of breast imaging. It has low dose radiation using standard measures of dose. It's the total dose of screening mammogram is only zero point 0.4 milli SB, which is very minimal if you compare it with other modalities. The radiation dose used for screening mammogram of both breasts is about the same amount of radiation a woman would get from the natural surrounding about 7 weeks, for a period of 7 weeks. So if you stay for about 7 weeks, you are getting the radiation, you are getting the same dose you are getting on the mammogram. So it's a very minimal dose. It's a natural surrounding radiation, so it's not harmful. The last thing I want to insist on, that having a normal mammogram is great news, but it doesn't guarantee that the future mammogram will be normal. So having mammogram every year for the age above 40 increases the detection of cancer when it is small. And when it's small, almost easily can be treated, and this will improve the survival. Just to show you here a picture to explain to you what I meant by dense breast. If you see the one on the left, this is a dense breast. This one, usually we see it in ladies who are young, premenopausal, or who are taking hormonal treatment therapy after menopause, or maybe some genetic predisposition in these ladies. So this breast, you can see that the breast tissue is very whitish. So if there is any small lesion behind, it will not be detected. That's why we kept them in the high risk group, because they need a proper evaluation. This breast is 50-50, dense and fatty. So you can see anything between, but still you will need another tool to examine the patient, just to know that there is nothing behind these dense breasts, dense tissues. The last one is the fatty replaced breast. Usually this is the breast of a lady postmenopausal. So it is very clear here that you can see any lesion in this fatty breast. That's why we say mammogram is very sensitive for ladies above the age of 40, and in Bahrain maybe above the age of 50, because we still have dense breasts at the age of 40. That's why it's a very good tool for ladies in the postmenopausal period. This is the ultrasound. If you just have a look on this picture, it shows you an irregular lesion. I mean irregular, that it's not smooth line surrounding all. It's irregular with breakage here. This is typical of cancer. This one also, if you have a look on it, it has a well-defined capsule, but at this area, the capsule is broken, which means that this is not typical of benign lesion. It goes more with cancer. These are also typical pictures of cancer. It's a good tool, done mainly below the age of 40, because as we said, in dense breast, we need something that can detect any changes in the breast. So below 40, the breast is not dense, it's very dense, so usually it's a good tool below the age of 40, or it should be combined with mammogram or MRI at any age. The last one is MRI. MRI also a very good tool, but usually it's not the first tool to go for. Usually we do MRI for patients who have very dense breast, or patients who have implants, and whom we are suspecting that they have multiple lesions in their breast. It's not the only lump we have felt by our hand. We think that, or suspect by other modalities, that they have multiple lesions. We do it just to make sure that this patient has only one lesion. So now we have finished the clinical examination in the triple assessment. We finished the radiological investigation, and now we'll go to the fine needle aspiration cytology or the core biopsy, which is the third pillar of diagnosing breast cancer. What do we mean by fine needle aspiration cytology? Is taking a sample from the lump by a fine needle, the same needle we are collecting blood from the lump. We use it to take cells, and they divide the result into C1 means cells 1, cell 2, from C1 to C5. If we want to speak about them more in detail, we would say that C1 is inadequate sample, C2 is benign.
بقصر على الصوت عشان اسمع صوتي ما هاي.
Is there any problem?
زين. أول مرة أجوز الجماعة.
Shall I continue?
You can continue,
Yes,
Doctor.
yes, you can continue.
So the fine needle aspiration cytology, we mean it's only collecting cells from the sample. So they can tell us that if it is benign or cancer according to the level. If it is C1, it means it's inadequate sample, have to be repeated. C2 is benign. C5 is cancer. C3 and C4, they are not sure and may need to be repeated by other means. The second one is core biopsy, which usually now we are depending on it. And it's not just collecting cells, it takes tissue from the lump itself or from the mass, and they see it under the microscope as a tissue, not as cells. And this one also divided from B1 to B5. Now let us go to the incidence. I cannot tell you that breast cancer is not the most common cancer among women. We have spoken before that about how to detect it early and treat it to get better survival. But breast cancer is still the most common cancer among women worldwide. We still have the same incidence. 1 in 8 women are diagnosed with breast cancer in their lifetime. In their lifetime. So this is an old map. It shows, if you see the blue color, you will see that the least areas which have breast cancer are the blue color, and in the Gulf, we are the lowest. We are the blue color. We are about 22 per 100,000. We develop these cases, but the highest is in North America and Australia, and somewhere in UK. So, but let us go with the incidence in Bahrain. Breast cancer is it's still accounting for 32 and sometimes 40% of all cancer. In Bahrain, in 1989, breast cancer accounted for 24% of all breast cancer in Bahraini women. In 2002, it has increased to 33.8% of all cancers in Bahraini women. And in 2014, it raised to 40% of all new cases in Bahraini women. So this means we are having increase in number of diagnoses of breast cancer in Bahrain. But it's just to give a good statement here also that I published a study in 2011. It showed that the early breast cancer is 70%. So if we can raise this number, breast cancer cannot defeat us because early treatment cures the patient, as you have seen, 100% cure. This is a study from the Ministry of Health. I've borrowed this slide. It shows to you that the age of presentation in Bahrain also is young. We have a surge at the age of 35, at the age of 45, I mean. And then again, another surge at the age of around 60, 66 and above. I did a study in Bahrain, which was published in 2009. We found out that 72% presents of our patients present below the age of 55 years. So if you have a look on this one, you will see that we have around 30% of our patients present between 35 to 45, 31 or 32% present between the age of 46 and 55, So almost between the age of 35 to 55, 60% of patients or 62% of patients present. We have patients with a low percentage at below 35, which is about 9.5%. So this means total we are presenting 72% below the age of 55. Why I'm showing this one to you? Because if we compare our study, my study, and the study from the Ministry of Health in Bahrain and USA, you will find out that breast cancer in USA is higher above the age of 55 or above the age of 50. It starts to become higher above the age of 50. But in Bahrain, it's higher below the age of 55. So we are having, from the slides, you can conclude that we are having patients at a younger age group than the international. I don't want to scare you, but we are still, I started with the positive statement that if we detect cancer early, the cure is obvious, 100%. So let us go to the causes of breast cancer. If we compare breast cancer to lung cancer, we cannot, because in lung cancer, we know that smoking is the principal and the powerful risk factor. But in breast cancer, there is no single most powerful factor. The strongest factors which everyone should consider is being a woman, as Sarah said at the beginning, advancing in age, I mean getting older, family history, which is very high. We found out here in Bahrain about 30% positive family history in patients with breast cancer. And although in the literature, international figures is only 5 to 10%, may reach to up to 15%. So we are double the percentage of family history, positive family history in breast cancer. So we have high family history. This means maybe because we are intermarriages, family marriages, maybe. That's why the gene became very strong here. But we don't have a study that shows that we have high percentage of BRCA2, BRCA1 and BRCA2 in Bahrain. And the fourth very strong factor is the previous breast cancer in the same patient. Let us go now to risk factors. I want you to go out from this awareness session, what to do, because there are things not in our hand. There are factors, risk factors that you cannot change. There are lifestyle-related risk factors that you can change, which I want you to go out with it. And there are factors that they don't have a clear effect on breast cancer, still under studies. So we cannot mention them or take them as a rule in our life. And there are some disproven breast cancer risk factors. So let us go step by step. I will discuss with you the breast cancer risk factors that you cannot change. Breast cancer risk factors that you cannot change, as I said before, being a woman, because the ratio between male and female to have breast cancer is 1 in 100%, in 100, 1 in 100. So male is 1% and females 99%. So getting older, as we said, family history, and I told you that we here in Bahrain have it 30%. We cannot change our family history. Personal history of a previous breast cancer for a lady who had previous breast cancer in her same breast or the other breast, she should be considered one of the factors who are very strong factors, but she cannot change it. Race, they found that the white women are more developed than African or Asian, as I showed you in the map. But Africans, Bahrainis, and the Gulf almost present at a younger age than Western Europe and US. Another also continuation of the factors that you cannot change, dense breast and mammogram. Dense breast and mammogram, it's something that you cannot change. And it's about 1.5 to 2 times more in women with breast cancer. So why there's dense breast? I told you before, it's normally high in young age, below the age of 40, and premenopausal patients who are still having their periods regularly, their periods did not stop, or they are taking oral hormonal replacement therapy after the menopause. They are taking tablets to replace the loss of their hormones, or they have any genetic related cause. Still, we are in breast cancer risk factors that you cannot change. Certain breast cancer diseases like atypia. Atypia means we find abnormal cells on histopathology report of a patient who took biopsy or had excision of a lump in the past. This patient needs close observation. Patient who had early menarche below the age of 12, or she had early menarche and she had her first period below the age of 12, or she had late menopause after 55 years of age. The last thing in these factors are radiation therapy. Some patients had radiation therapy for example, another cancer like lymphoma in the past to their chest and neck, which make them predisposed to have breast cancer. Let us go now to the factors that we can change, because if we improve them, we will lower the risk very high. We will lower it to a good extent. So it's a lifestyle related breast cancer factors that you can change. First, people who are eating unbalanced diet and they are overweight, they are more predisposed to develop breast cancer, especially postmenopausal. They don't do any physical activity. Late marriages with late pregnancy after the age of 35, no breastfeeding. They are taking hormonal birth control methods for prolonged periods, like oral contraceptive pills, IUCD, which has hormonal element, birth control shots, others. If we can avoid them, this will be better. Hormonal replacement therapy, this I told you about, after menopause, or ladies who had surgery for their ovaries at an early stage and they take hormonal replacement therapy. And the last, smoking and drinking alcohol. So these factors, we can control them. We can improve our diet. We can have children early. We can breastfeed them, stop taking hormonal replacement therapy after menopause, stop smoking and drinking alcohol. So let us go now to the factors with unclear effects on breast cancer. Diet. You hear a lot about eat low fat, eat red meat and processed meat as reducing breast cancer. You should eat high fruits, vegetables. These are all have clear benefits, but it can affect also the cancer, but it hasn't been proved clearly that if we do this, we'll avoid developing breast cancer. Chemicals in the environment. There are some chemicals on estrogen, like special interests such as plastics, certain cosmetics, personal care products, pesticides. Research does not show any clear link, but they are still under work on this. Night shift work. Maybe Zainab became afraid now after hearing this statement. Night shift work, which is usually by nurses, there was a lot of talk about it, that it can predispose to breast cancer, but there are no clear or proven effect on it. And they are saying that maybe due to changes in the level of melatonin hormone. I don't want to increase now the subject to make you get bored, but the last factor is the disproven breast cancer risk factors, which usually patients are asking me all the time. Antiperspirants, deodorants, there is no proven effect that it can cause breast cancer. Wired bra, induced abortion, plastic breast surgery such as breast implant, still nothing is mentioned about them predisposing the patient to develop breast cancer. So how to prevent ourselves from developing breast cancer? By working on the risk factors that can be controlled by our hand. So we should control obesity by exercise. We should not get married very late. We try to get married early, have children below the age of 35, and breastfeed them all. Stop drinking alcohol or smoking. Thank God it's forbidden, alhamdulillah, in our religion. And try to get rid of hormonal replacement therapy after the post-menopause. So let us now conclude and add a few things. Many patients say, so how can I lower my risk of breast cancer? Or how can I lower my development of breast cancer incidence? First, as we said, the lifestyle changes, which will lower the risk-like factors like control weight, be physically active, avoid alcohol and cigarette smoking, get married early, get pregnant early, breastfeed all your children for 2 years or more. Avoid for 2 years, not more, and avoid HRT after menopause. The second thing is practice regular breast self-examination. The third thing, we have to keep the high-risk group who have strong family history in a category that they have to consult the breast specialist at an early age. And the fourth thing is whenever you have symptoms, you have to go to a doctor, and after the age of 40, you have to go for regular screening. This is a video which will show you breast self-examination, but I think it will not work as the previous video. So we can discuss it. There's a lot of videos in the YouTube that you can go through, and we can discuss it later with the questions if anyone wants to ask about this thing. If I'm in the high risk group, can I lower my risk? Yeah. If someone is in the high risk group, like he has a family history of breast cancer, or he had previously had genetic testing and it came positive, if the result is positive, then we can offer three options. Either close observation, which is the commonest way of dealing with patients here in Bahrain. Close observation by doing triple assessment on regular basis every 6 months from the age of 35 or maybe even earlier than 35. Second, this only for the people who had genetic testing and came positive. We give anti-estrogen drugs like tamoxifen for 2 years. The third is prophylactic surgery to remove both breasts and both ovaries. It will lower the risk, but it does not eliminate it. Even the surgery, it will lower the risk, but it doesn't eliminate it. So that's why we have to be cautious in these subjects, and we have to discuss it with a balanced surgeon who wants to take the right decision according to the case. All of us know about Angelina, who had breast cancer in her mother and grandmother. After the death of her mother, she went and did the genetic testing and came positive. Then she decided to go for bilateral prophylactic mastectomy. We mean prophylactic, to remove her breast in a preventive measure before developing any breast cancer. And bilateral ovarian ovarectomy. So she has, this after that, this made a lot of discussion and increased the number of ladies who went for bilateral prophylactic mastectomies. So if we do this one, if we have a positive result, this will significantly more, you are more at risk, and you have to choose one of the options we said before. If you have negative results, you are not genetically predisposed, and you don't have to go for these options. If there's a result which is ambiguous, means equivocal, not positive or negative, then this means that you don't have these genes. So management, I don't know if I still have time. If you want me to finish quickly now, so I have time for questions, or I can go to management.
Yes, we have 10 minutes.
Okay.
12 minutes to be precise.
Okay. About the management, we divide usually our management according to the stage of the disease. We call early breast cancer is a cancer which is smaller than 5 centimeters with lymph nodes, moderate number of lymph nodes, but it's not beyond the breast, it's all within the breast. Locally advanced, it's a big tumor which has reached the skin, or it has involved the muscles, even sometimes small tumors which have involved the skin or the muscles, we consider them also as locally advanced, means they are locally in the breast, they have reached a high level, with axillary lymph nodes also involvement. And the third stage is the advanced. We call it systemic or advanced, which means that the cancer has gone beyond the breast to the circulation and has settled in one of the major organs, like the lung, liver, and bone, which is the commonest places where breast cancer metastasizes. So the management depends on the stage. For early breast cancer, as we said, the survival rate is very high, and we can give them two options. The first option is breast conserving surgery, which is it's an oncoplastic breast surgery. We remove the tumor with the normal tissue around it, and we do a plastic surgery for the breast, so the tumor will not disfigure her breast after removal. And we do at the same time something called sentinel lymph node, which I would like to know about it. And if the sentinel lymph node is positive, then we remove more lymph nodes from the axilla. These patients, they will go later for chemotherapy and hormonal therapy. And if they are, according to the receptors which we are measuring in their histopathology report, they will go also for Herceptin. But usually in early breast cancer, we can give them also the two options, either to go for breast oncoplastic surgery or for mastectomy. Mastectomy means excision of the whole breast. And there are a lot of types now for excising the breast, either by excising the breast in the traditional way in the past, or by leaving a skin envelope that we can keep an implant under it, or by doing a nipple sparing. I mean, the nipple is not involved, so we leave it behind and we keep an implant behind it. But usually all these patients will receive chemotherapy, hormonal therapy, and maybe Herceptin. Let me speak about sentinel lymph node, this word. What does it mean? Sentinel lymph node biopsy. It means that before we used to remove there are 3 levels of lymph nodes in the axilla. Usually, we used to before to remove 2 levels, and a lot of patients developed some swelling in their arm after surgery, which was very debilitating and difficult to treat, and they used to go for physiotherapy for many months and even years. And there was no clear treatment for it before except physiotherapy. Although nowadays there are treatment for lymphedema by surgery. So what is sentinel lymph node? We try to remove the first lymph node which the tumor goes to by injecting a dye during surgery and removing that lymph node and sending it for analysis while the patient is under anesthesia. And if it is positive, means if this lymph node, the first lymph node, the dye has gone to, is positive for cancer, then we proceed by removing the remaining lymph nodes. This has changed a lot and reduced the number of complications or problems happening after the surgery. For locally advanced breast cancer, we have to do sentinel lymph node biopsy for these patients, or fine needle aspiration cytology of these axillary lymph nodes before surgery, and maybe to mark them by a clip. Then we give these patients chemotherapy before surgery. We call it a neoadjuvant chemotherapy to downstage their disease, because we said locally advanced means the tumor is very big, so we want it to become smaller. So to make it smaller, we have to give them chemotherapy before surgery. If they respond well to the chemotherapy and the tumor became smaller and the lymph nodes has disappeared or became smaller, then we can go ahead and give them the chance of doing also oncoplastic breast surgery, remove the tumor with wide margin, with free margin, and do an oncoplastic that will not disfigure her breast afterwards. And then she can make a surgery at the same time for the other breast to make it smaller to the breast of where she had surgery, and then go for radiotherapy after the operation. But during this operation, if the sentinel lymph node was positive, then we can go ahead and do the same which we used to do in the past by removing level 1 and level 2 lymph nodes. For metastatic system, that is very difficult to help the patient because this is the level which surgeon does only palliative. He doesn't do curative resection. Curative means I do a curative resection. I remove the whole tumor with free margin. So we don't want to see patients in this level. We don't want to see patients even in locally advanced. We do want only to see patients in the early breast cancer. Locally advanced also, there is a high chance. We said their five-year survival is reaching 70%. We don't want to do operations or see in Bahrain patients with locally advanced breast cancer. They have to present early. We have to go all for screening before developing any breast cancer. As we said, and I will go back to that slide because this is the slide which I want you to go out with your memories, that we have to diagnose breast cancer at an early stage. Locally advanced and metastatic or systemic disease are a group of patients whom the five-year survival will be very low. In this case here, internationally, it reaches up to 22%. But in our group, and the one I studied, it has reached up to 50%. But this group means that the tumor has gone beyond their breast. It has gone to the lung, liver, or bone. There's a lot of improvement with treatment now. That's why I'm saying also this has helped in improving the survival. But still, we don't want to see patients in this. In the European Society and in the USA, they don't see patients in this group. They see in early breast cancer or screen patients. So in conclusion, early detection of breast cancer is our aim as it leads to early treatment. Early treatment at very early stages means improved five-year survival. High-risk group should have early screening. In Bahrain, as I told you, the age at presentation is younger than the Western world. And we have a positive family history. This means that we have to have a screening program at an early stage, and ladies should learn how to do breast self-examination and go for triple assessment at an early stage, especially if they have family history. The factors which is in our hand, we have to control by controlling weight, eating balanced diet, going for exercise, early marriage. I think all of you wants to have early marriage and have childbirth, breastfeeding, avoid long use of OCP or HRT, avoid smoking and alcohol. Thank you. I hope I elaborated all the questions in mind, but if you have, I'm ready to answer any question.
Thank you, Mrs. Suhair. As I stated earlier, if you have any questions, kindly please just type your questions and we will be able to see it in the chat. You may ask your questions again only in the chat, and I will start with the first question, Mrs. Suhair. My question is that you stated earlier about the genetic testing. Is it available in Bahrain or not? And if it's available in Bahrain, in which hospital is it available?
It's available in Bahrain. We are usually sending our patient to King Hamad to do it, but I think there are King Hamad Hospital. But I think there are some other hospitals like or Al Burj. I think Al Burj are doing it, and even the private hospitals we can request them to do it. They send it abroad to a well-recognized lab because not all labs are recognized for genetic testing. So it should be sent to a well-recognized lab to get the result. Because you know, if you do genetic testing, you have to take decision. If you are not ready to take these decisions, don't do the genetic testing. But it is done usually here in Bahrain, King Hamad.
All right. Okay. Thank you so much. So we will start now with the questions. So we have the first question from badge number 10327. I'm not able to see the name. However, the questions, she has actually two questions. The first question: is there a family history of other types of cancer? Will it still affect the possibility of developing breast cancer? Is there a connection? So, yes. Is there a connection between irregularities and uterus and breast cancer?
There is a connection between, there are many genes which have been recognized to develop breast cancer. Most common genes we are testing patients for is BRCA1 and BRCA2. So it is related to CA colon, CA ovary, and CA prostate in men. So if you have a family history of any of these three, CA breast, four, CA breast, CA ovary, CA colon, or CA prostate, then you are supposed to do genetic testing. I mean first degree relative, not just any family history, first degree relative, which is the mother, the sister, or the daughter, the daughter. Okay.
Okay, thank you, Dr. Suhair. So far, I only have those two questions, and due to the time constraint, we're gonna have to end the session for today. Thank you all for joining. Just a short story about myself before I end this session. Actually, my mother, Allah yarhamha, she passed away from breast cancer 12 years ago. And that happened because she discovered it too late. When she discovered it, she was already in the fourth stage. Actually, she was getting symptoms before that, but she was afraid to go to the hospital, and she was actually also ignoring the symptoms. And when she came to find about it, it was already very late. Yet she was lucky to survive and to live for 4 or 5 years, I guess. But yeah, eventually she passed away from breast cancer, and it got spread it also to her lungs and to her bones. So, as I stated earlier at the beginning of the session, it is always our duty to ourselves, to our precious selves, to protect ourselves from everything. So, I hope you all benefited from the session today, and I hope to see you very soon. Thank you, Dr. Suhair, and thank you everyone for joining. Have a lovely day.
Thank you. Thank you. I hope you have already know what is the important things in breast cancer awareness by the end of my lecture. Thank you very
Yes,
much.
yes, we benefited a lot. Thank you indeed, Dr. Suhair, and I hope you all have a lovely day. Thank you so much for joining, and have a good day. Bye bye.